Good afternoon, everyone. Greetings from India, and I acknowledge the honor given to me to participate in Kenya Renal Association Conference 2022. And my topic today is bone diseases in transplant. So before I start my talk, let me pose this question to all of you. So how many of you routinely do calcium, phosphorus, vitamin D, PTH, and DEXA scan in post-transplant patients? And when do you do it? So we'll address this question at the end of my talk once again. So my talk comprises of introduction, risk factors, types of bone disease post-transplant, how to evaluate at-risk patients, and finally, management, which includes prevention and treatment of bone disease post-transplant. So coming to introduction, so bone disease post-transplant is actually poorly addressed issue, but it is a significant issue. It not only increases morbidity and hospitalization, it also increases financial burden of our patients. When the question comes in, what happens to bones post-transplant? So there is rapid loss of bone mass in early post-transplant period that frequently affects trabecular bone, which means vertebrae and end of long bones, because of decreased bone formation, predominantly as a result of steroid therapy. Although cortical bone may also be affected. This is in contrast with pre-transplant or chronic kidney disease patients where cortical bone is predominantly affected, and that is because of hyperparathyroidism. A study published about a decade back reported that recipients managed with steroids experienced a 2.9% bone loss at the spine over first 6 months. However, more contemporary studies suggest that after first post-transplant year, on an average, bone density remains stable. Another question comes to my mind is what happens to these bone minerals after transplant? So let's see one by one what happens to these minerals. To begin with, PTH, which decreases by 50% in first 6 months after transplant, but it can remain high in 45% of transplant recipients even after 2 years. High PTH values correlate with significant bone loss at the hip, but the optimal post-transplant PTH levels actually remains unknown. So we don't know what should be the target PTH levels at various time period post-transplant. What about calcium? So serum calcium usually follows a biphasic pattern with an initial fall in calcium level in first few weeks. And this is probably secondary to significant fall in PTH, which I just mentioned. And this is followed by a rise in serum calcium, reflecting a combination of increased vitamin D production from the allograft and persistence of secondary hyperparathyroidism post-transplant period. Now, hypercalcemia has been reported in about 5 to 15% of patients and is most prevalent 3 to 6 months after transplantation. And that again is because of persistence of hyperparathyroidism. What happens to phosphorus? Hypophosphatemia is more common in early post-transplant period, and it occurs more than 50% of incident kidney transplant recipients. And this reflects an improvement in excrete kidney function, elevated PTH levels, and an increase in renal tubular sensitivity to PTH and FGF23. Most of these cases are self-limiting, and they come back to normal phosphorus levels very soon. However, hypophosphatemia has been associated with severe alterations in bone turnover, such as decrease in osteoblastic activity and defective mineralization. And the last mineral is vitamin D. Deficiency in vitamin D is seen in 30% of kidney transplant recipients. And even if allograft function normalizes, vitamin D often remains low. This persistent vitamin D deficiency leads to hypocalcemia and abnormal bone mineralization. So this is what happens post-transplant in minerals. Now coming to what are the risk factors for these bone diseases post-transplant. So it can be broadly divided into 3 categories: pre-transplant factors, transplant factors, and post-transplant factors. Let us see one by one in short. So what are the pre-transplant factors which affect and cause bone diseases post-transplant? So previous osteodystrophy at the time of chronic kidney disease contributes to bone disease post-transplant. Longer the time on dialysis also contributes to increased incidence of post-transplant bone disease. Use of tobacco, alcohol, low exercise, and low BMI also contributes. Similarly, deficiency of calcium and vitamin D, gender, presence of diabetes, certain drugs, including transplant drugs, aging and poor nutrition are certain factors which contributes to, they are factors pre-transplant which contributes to post-transplant bone diseases. What are the transplant-related factors? And these are modifiable factors. And the two most common are use of steroids and persistence of secondary hyperparathyroidism, which contributes to post-transplant bone diseases. And finally, the third is post-transplant factors, which includes progressive graft dysfunction. As you know, as the transplant ages, there is bound to have graft dysfunction. So this natural history of transplant, certain drugs like CNIs and sirolimus, and incidences of rejection, all these contribute to post-transplant bone diseases. So apart from this, other risk factors include post-transplant metabolic acidosis, and you'll be surprised that many of these patients have certain degree of metabolic acidosis in initial post-transplant period also. And those who receive kidney pancreas transplant as compared to kidney alone transplant have higher risk of post-transplant bone disease. And persistent hyperparathyroidism contributes to higher fracture risk in kidney transplant recipients compared to any other solid organ transplants. So these are certain risk factors which are universal in causing post-transplant bone disease. Now we come to type of bone diseases. So broadly, we divide post-transplant bone disease in 4 categories. First is osteoporosis. Second is bone fractures. Now these are both interrelated, so I'll be discussing these two together in my subsequent part of my talk. The third is renal osteodystrophy or persistent hyperparathyroidism, and the fourth is osteonecrosis. So briefly, I'll touch upon third and fourth, but mostly I'll talk about osteoporosis and bone fracture. Here, a point of caution is the prevalence of histologic patterns of post-transplant bone disease is not very well defined because there have been very few bone biopsy studies in kidney transplant recipients. So coming to the first bone disease, which is osteoporosis, which is defined as reduction in bone mass with microarchitectural deterioration of bone tissue and subsequent increase in bone fragility and susceptibility to fracture. And we all know that T-score less than 2.5 is indicative of osteoporosis. And bone mineral density declines by 4 to 10% in first 6 months, as I've already pointed out. Predominant bone losses in first 6 months, after which there is a subtle decline in BMD, and subsequent studies, it may remain stable as well. So the risk factors which I have highlighted is in general holds true for osteoporosis. In addition, there are certain risk factors like younger age at transplant, poor nutrition, hypogonadal status, and hypomagnesemia, which also contributes to osteoporosis, which one has to address while managing bone disease or osteoporosis post-transplant. Coming to risk factors for bone fractures. So bone fractures, actually, if you see the incidence, it is 4 times higher post-transplant period as compared to general population. And in one study, in first 5 years, the bone fractures were 22.5%, which is a significant morbidity burden. The most common location of bone fracture has been hip and ankle or foot. And not only the morbidity, it has been seen that as compared to general population, there is 60% increased risk of mortality after fracture post-transplant period. So one has to manage this as a prevention rather than just a treatment. And risk factor for fracture, apart from the one which I have already mentioned, includes lumbar osteoporosis or non-vertebral fractures, pre-existing history of fractures, and most importantly, risk of falls, which includes postural instability, decreased visual acuity, peripheral vascular disease, peripheral neuropathy, orthostatic hypotension, and certain drugs like hypnotics and antihypertensive drugs, which can also cause orthostatic hypotension. So these are in addition risk factors for fractures. One important other risk factors is the use of proton pump inhibitors, which we sometimes use in post-transplant period. And this is a risk factor in general population as well. So one should limit the use of PPIs in post-transplant period for a longer period of time. So these were risk factors for osteoporosis and fractures. How do you evaluate for these risk factors who are at risk post-transplant? So the idea is to screen all kidney transplant candidates for osteoporosis and fracture prior to transplantation. And in this context, what studies and we suggest is one should do a PTH, vitamin D levels, and DEXA to assess bone mineral density. And also to assess for the presence of traditional clinical risk factors, which I have mentioned, so that we can take care of them even before transplant is done. Now, in deceased donor transplants, the initial DEXA should be done at the time of evaluation. And while on waiting list, DEXA should be repeated every 2 years so as to document what is the status of bone before transplant. However, in living donor kidney transplant, because the waiting period is very short, this DEXA and all these workups should be included in preoperative evaluation like we do for many other things. So that also should be included with DEXA and PTH vitamin D levels. For patients who have missed out in pre-transplant evaluation, it should be done within 3 months after transplant, so that necessary action can be taken as early as possible. Apart from this, after 2 to 4 weeks after transplantation, when we presume that kidney allograft function has stabilized, one should measure calcium, phosphorus, PTH, and vitamin D levels. In addition, in some centers, they go higher than this in evaluation, and they do fasting morning serum concentration of bone turnover markers, including C-telopeptide cross-link and bone-specific alkaline phosphatase. However, utility of these markers, which are not routinely available in all centers, are limited in terms of adequate sensitivity and specificity in predicting bone loss or bone structure and function. So we do not routinely do these high markers. So 2 additional tests I would like to highlight of clinical significance. One is CT scan and another one is bone biopsy. So DEXA actually is unable to assess microarchitectural structure of the bone. In contrast, high resolution peripheral quantitative CT scan of distal tibia and radius provides microarchitectural information and is able to quantify volumetric density of cortical and trabecular bone. So it's a very promising research tool, but unfortunately there are no studies to show whether it is better predictor of fracture than DEXA in kidney transplant recipients. So it's again a research tool. In future, probably it may be available in routine use. Another one important is bone biopsy. Though we understand that it's a gold standard for diagnosis of post-transplant bone disease in kidney transplant recipients, the major limitation of bone biopsies are the only few centers have the expertise to properly process and analyze bone biopsy specimens. Hence, this is also not routinely used in management of bone disease post-transplant. So that was about the risk and evaluation of risk at-risk patients for osteoporosis and fractures. Now coming to prevention of osteoporosis and fracture and how to treat it. So as far as prevention is concerned, there are general measures and specific measures. So general measures applies to all transplant recipients, which includes lifestyle changes. And lifestyle changes includes weight-bearing exercise after transplant, cessation of smoking, early mobilization after transplant, and fall prevention, which I have already told while discussing risk factors of fractures. So all these measures are uniform to all transplant recipients. Then coming to specific preventive measures to prevent osteoporosis and fractures. And no, again, in general, you should also minimize the use of glucocorticoid dose, provided the calcium is normal, treat with calcium and vitamin D3, treat persistent hyperparathyroidism, and evaluate for other causes of bone loss, which can be treated specifically. So these are general measures by which we prevent osteoporosis and fracture in post-transplant period. Apart from this, now we come to specific treatment for prevention of bone disease, osteoporosis and fracture post-transplant. And this depends in first year, one has to assess the bone turnover. Now, as I said, bone biopsies are not routinely available, so we are dependent on markers, and easily available marker is PTH, and some centers who can do bone-specific alkaline phosphatase. These two are markers which can give us an idea whether the turnover is low turnover or high turnover. And there was a study which quoted that PTH of less than 79 units and BSAP, that is bone-specific alkaline phosphatase, of less than 12.9 have a predictive value of almost 90% towards low turnover bone disease. So whatever measure you use, if you categorize between low turnover and high turnover, those who have low turnover bone disease, the recommendation is to use active vitamin D analog, calcitriol. Some centers can take teriparatide as a first-line treatment to prevent osteoporosis fracture in first-year transplant. Those patients who have normal or high bone turnover Anti-resorptive treatments like oral bisphosphonate or denosumab is indicated in first year post-transplant. So these are preventive measures, specific preventive measures regards osteoporosis and fracture prevention. That was in first year. What about after first year? After first year, it depends upon what is the dose of steroid. So those who are steroid withdrawn or have steroid less than 5 milligram, actually these measures can be discontinued except for those who use denosumab and there might be rebound osteoporosis fracture. One should use oral bisphosphonate for about 1 more year. And those who are having steroid more than 5 milligram per day, it is suggested that these measures should be continued for another 1 year, get a BMD, and then only withdraw these specific treatments. So that was about preventive measures. What about the treatment? Now, treatment, actually, the optimal approach is not known. One is to follow with stepwise approach. Step 1 is, again, lifestyle changes, calcium, vitamin D, lowest possible dose of glucocorticoids. In one analysis of USRDS data, it showed that early steroid withdrawal was associated with 31% fracture risk reduction and lower fracture-related hospitalization without an increased risk of rejection. Step 2 is, if there is persistent hyperparathyroidism and or hypophosphatemia, one should treat this first before going to specific management of osteoporosis. Step 3 is anti-resorptive treatment. I have already highlighted in preventive measures. However, anti-resorptive agent should not be used in patients with low turnover bone disease. And you have denosumab versus bisphosphonate to use in this. And those who have low turnover bone disease, recombinant human PTH, that is teriparatide, is suggested to be used. So these are some treatment measures for osteoporosis and fractures. So I have covered the first 2 bone diseases. Now I'm coming to the third and fourth. In next 5 to 10 minutes, I'll try to finish this off. About persistent hyperparathyroidism, about 15 to 50% of patients after transplant can have persistent hyperparathyroidism. Most of the others resolve as the GFR normalizes. And this is because of persistence of structural changes in parathyroid glands, such as hyperplasia and adenoma. The clinical manifestations actually post-transplant resemble primary hyperparathyroidism. That means they have hypercalcemia and hypophosphatemia, in contrast to those in chronic kidney disease where they have hypocalcemia and hyperphosphatemia. The symptoms of bone pain, pruritus, nephrolithiasis, and myopathy are generally not observed post-transplant period. This persistent hyperparathyroidism leads to increased mortality, graft loss, and obviously bone disease and fracture. And one of the multivariate analysis, including 1600 plus transplant recipients in ALERT trial, showed that PTH more than 65 units was associated with increase in all-cause mortality. And this is predominantly because of vascular calcification and cardiovascular deaths. In the same trial, it also showed that PTH more than 65 picogram per ml was associated with 85% increase in death-censored graft loss. So it does affect the graft survival as well independently. That is also a very important finding. And another study showed that persistent hyperparathyroidism increases 7.5-fold risk of fracture over next 5 years. So these are the morbidities which are associated with persistent hyperparathyroidism. Hence, we need to prevent and treat hyperparathyroidism. The experts suggest, how do you prevent it? The experts suggest that even before patient goes for transplant, it is wise to do a subtotal parathyroidectomy in 2 circumstances. One, if the hyperparathyroidism is refractory and the patient has moderate to severe symptoms. And number 2, if the PTH levels are more than 800, even in the absence of symptoms. In these 2 categories, it's wise to do a subtotal parathyroidectomy pre-transplant. And the reason is that it is very difficult to control these high level of thresholds with medical management. And also a reason that parathyroidectomy is safer if performed prior to transplant rather than considering it post-transplant. And it has also been noted that parathyroidectomy after transplant has been associated with abrupt deterioration of kidney allograft function. Yeah, so after prevention, how do you treat secondary hyperparathyroidism or persistent hyperparathyroidism post-transplant? And that depends upon presence or absence of hypercalcemia, hypophosphatemia, and vitamin D levels. So if there is mild to moderate hypercalcemia, it can be treated with calcium mimetics, that is Cinacalcet. But one has to be very careful because Cinacalcet may reduce blood TAC levels, in which case you have to do frequent TAC monitoring in such cases. Calcium levels need to be monitored every 2 weeks, and that is how we titrate the dose of Cinacalcet. And if patients do not respond to calcium mimetics within 6 to 12 months, then probably subtotal parathyroidectomy will be indicated in such patients. If there is severe hypercalcemia, it is again wise to undergo parathyroidectomy rather than give a trial of Cinacalcet, which depending upon individual patient's need can be practiced. What about the phosphate levels? If there is mild to moderate hypophosphatemia and hyperparathyroidism, it is better to treat hyperparathyroidism first, because once that is treated, hypophosphatemia will resolve. And in addition to that, if somebody wants, intake of phosphate-rich foods or phosphate supplements can be added as well. But in presence of severe hypophosphatemia, oral phosphate supplements are also indicated. Vitamin D derivatives also help, and then consider parathyroidectomy if these measures fail. And those patients who have high PTH but normal calcium levels, they can be managed with vitamin D, cholecalciferol, activated vitamin D, calcitriol, because these patients do not have hypercalcemia. So that was my third bone disease. Last bone disease is osteonecrosis, and transplant physicians are more aware of this because we are very concerned about this debilitating disease post-transplant. Now, among transplant recipients, factors that contribute to osteonecrosis include uremia-induced defects in mineral metabolism and certain immunosuppressive medications as well. Glucocorticoid obviously play a central role. Some studies also suggest that cyclosporin is also associated with osteonecrosis. And apart from that, osteopenia and hyperparathyroidism also may contribute. So osteonecrosis, as everyone knows, is avascular or ischemic necrosis. And as I said, it's one of the most debilitating musculoskeletal. Pain is the most common presentation of osteonecrosis. And as in non-transplant population, the weight-bearing long bones are most often affected, particularly the femoral head. Among transplant recipients, osteonecrosis is commonly multifocal, and about 50 to 70% of patients have more than one bone involved. Before I end my all disease, one interesting bone pain syndrome I wanted to highlight, and this has been noted in certain case reports associated with use of cyclosporin, possibly all CNIs. And there is a temporal relation to high levels of CNIs with bone pain syndrome. The exact mechanism is not clear, but possibly intraosseous vasoconstriction and hypertension play a role. And there are characteristic MRI findings that are consistent with edema and subclinical trauma. This can be managed with long-acting calcium channel blockers, and obviously reduction of CNI dose in most of the cases reduces the symptoms. So here I end my talk, and I pose this question once again. With this talk in mind, I'm sure that at least certain percentage of the audience now would routinely do calcium, phosphorus, vitamin D, PTH, and DEXA post-transplant. And to quickly summarize my talk, one should address the issue of post-transplant bone disease at the start of workup transplant itself, rather than considering it after transplant. And one should include DEXA in pre-transplant workup routinely, whether it is living donor transplant or deceased donor transplant. Not only that, while doing a workup, if there is osteoporosis or hyperparathyroidism, it is better to manage pre-transplant to have a better outcome post-transplant, if that is possible. And once the transplant is done, routinely one should follow with calcium, phosphorus, PTH, and vitamin D in first 2 to 4 weeks, and subsequently as per the requirement of the patient. And BMD, if it has been missed earlier pre-transplant, within 3 months, and then probably 6 months or 12 months, depending upon the finding post-transplant in the first BMD. One should prevent and treat osteoporosis and all those who have high risk of bone disease post-transplant. So I think here I end, and again, sincerely thank the CRACON to have given me this opportunity to participate in this conference. And I'll be happy to take comments and questions now. Thank you so much.